Hello, everyone. Apologies for the delay for the technical issue. Um, Extremely sorry for this issue, but we'll give a couple of minutes. People have been requesting me or asking me about this webinar, so we'll take a couple of minutes. Hi, Sarang, how are you?
Very good, thanks. Hello, everyone.
Good evening, Sarang.
Nice to see you after a long time.
Hi, Sajata. Good to see you too.
How are you?
Very well, thanks.
Hi, Sarang. GC here.
Hi, GC. Good evening.
Good to see you.
Thank you.
So, Sarang, you have your slides ready, right? I'll give a brief introduction about you, and then maybe Arnas can give you the post.
Sure, sounds good.
So I think we'll start now, Arnas, if that's okay.
Yes,
Um,
sure.
So it's our pleasure today to have Professor Sarang Deo. He needs actually no introduction for those who are at LVP and also in healthcare. But briefly, he is a professor of operations management at the Indian School of Business, and his primary area of interest is healthcare operations. He has studied the influence of vaccine supply and the adult HIV treatment supply chains. And currently, he's working on COVID vaccination cost effectiveness. He has collaborations with numerous national and international agencies, and also he works on numerous national committees of different state governments and also the government of India. He has collaborated with the Clinton Health Access Initiative and also the Bill and Melinda Gates Foundation. Prior to joining ISB, Professor Sarang Deo was working at was a faculty at the Kellogg School of Management, and he did his PhD from UCLA Anderson School of Management. He did his MBA from IIM Ahmedabad and also his BTech from IIT Bombay. So you can imagine how strong his credentials are. And without wasting any further time, we request now Professor Sarang Deo to give his talk on cost effectiveness of COVID-19 vaccination policies. Over to you, Sarang.
Thank you, Raja. It's great to be presenting to this audience. IHOPE has been doing some wonderful work, so I'm quite excited to share whatever work we are currently doing on COVID vaccination with this group. I'm looking forward to getting feedback and comments. I thought Raja was going to say, without embarrassing Sarang further, let me hand over to him. It's a very, very kind introduction, Raja. Thank you. Arnas, can I share my screen?
Yes, yes.
Okay, perfect. Here it is. Okay. Yeah, so as Dr. Raja said, this is ongoing work. This is also a difficult topic to present because hardly I can imagine anyone who's not been affected by COVID-19. And so, it's a topic that may touch raw nerves for some people, but, such is the nature of this kind of work. We began this work 5-6 months ago when vaccination was just sort of a talk, just a discussion point. And we were fortunate to be funded by Center for Global Development Europe to do some of this analysis. I am just one of the team members. There are a lot of people involved in this analysis. I have mentioned their names here. Shripad Devalkar is a colleague in the operations area at ISB, works in supply chains. Abhishek Reddy is our research associate on this project. Nim Pathi and Sandeep Mandal are the epidemiological modelers, transmission modelers who we are collaborating with. And then Hiral, Abha, Francis, Prashant are from the Center for Global Development. I see that Hiral is on the call. And of course, beyond the immediate team, we've got feedback and inputs from several people that we have presented our work to at various stages during this development. I want to thank Sushmita Chatterjee at the George Institute. She has a lot of knowledge on costing of supply chains, vaccine supply chains, and she was instrumental in ensuring that our model was appropriately validated. So I'll come to that subsequently. And then we've reached out to several agencies, as Raja said, those who are either involved in direct implementation or influencing the policy, and happy to have more of that discussion as we go forward. So that's sort of the long preamble of how this work began, where it is currently. This, again, this is obvious to many people now. This slide is kind of dated. This was around the time when shortages were looming. It was clear that we will not have enough vaccines to vaccinate adequate proportion of people at an adequate or satisfactory rate. And so that, when we started the work, we had two sorts of constraints in mind. One was the supply of vaccine constraint, and the other was the capacity of vaccine delivery and distribution constraint. And as time progressed, it is sort of becoming clear, at least for the time being, that the supply is going to be a tighter constraint than the delivery and distribution capacity. Nonetheless, the model that I will show you accommodates all these different kinds of constraints. And by the way, just feel free to stop me at any point in time. I can imagine that this area may not be your primary area of work, either in terms of infectious diseases or modeling, cost effectiveness modeling. So, at any point in time, absolutely stop me. I'll try to keep track on the chat as well. Yeah, so Raja has said you can post in the chat box, but please unmute and directly ask the question or raise your hand, whichever way works. I'm completely fine with that. Okay, so let me go forward. So again, some of these slides were presented to members of Niti Aayog when vaccine supply constraint was becoming apparent. And we just sort of simply put together the demand and supply. Demand as measured by the peak vaccination rate at the beginning of April, which was really the maximum that we've ever done in this country. He said, hey, if I hold that constant, is it possible for me to sustain that rate of vaccination? And then juxtapose that against the projections of supply. Again, these are at national level. The situation will be different from state to state. Within state now, of course, we've complicated the supply chain so much within each district, private, public, things may change. But broadly, we're not looking to alleviate the supply constraint anytime soon, at least until August. And so then in the immediate term, the question becomes, if we have a constrained source of vaccine supply, what is the best way to allocate this constrained resource so as to maximize the societal impact that this vaccine can have? The shortage situation is far more stark today. But even, let's say, 3-4 months down the line, say in August, as production ramps up, if demand picks up again, we will again find ourselves in a relative shortage position. And if supply increases even further, then at some point, the capacity delivery may become a constraint. So, we are a resource constrained health system. And so this question is never likely to go away, saying, I can't vaccinate all the people immediately at the press of a button. And so what is the best strategy that we can adopt to allocate the scarce resource of vaccination within our population? And when we say the best way, a lens that is typically used is what we call as cost effectiveness. On one hand, calculate the cost of a certain strategy of allocating vaccine across the population. And on the other hand, calculate the effectiveness of these different strategies. The cost, I'll show you going forward, will be calculated by developing a supply chain model of COVID vaccination. And it's a model because we can't go out into the field and collect actual cost data on how much does it cost to move one vial of COVID-19 from a state vaccine store to a district vaccine store and then to a hospital. That kind of analysis is impossible. And so we are going to rely on mathematical modeling, but then ensure that such models have validity. We can cross-check the outcomes of these models against some past data that we may have. So that's on the supply chain side to calculate costs. And roughly speaking, imagine not just the physical cost of transportation and storage, but it can be also personnel involved, people who actually administer the vaccine. There may be supervisory staff. So all of those costs are being captured. I'm using supply chain very broadly. I mean, there are various functions within the supply chain. Then the effectiveness part, we are going to capture by a metric, which is how many deaths can be averted by vaccinating the population using different strategies. Again, deaths is one metric. One could use hospitalization. One could use, severe illnesses averted. We have to start somewhere, and so we decided to pick deaths. And then that is being calculated through what we call as transmission modeling or epidemiological modeling. Has become popular these days because of, again, COVID-19, a lot of discussions of SIR models, SCIR models, SEIRD models, Sutra models. So ours is a variant of the classic SCIR model, nothing fancy. And we try to calibrate it to the best extent possible with the data that we have in India. And then the idea would be to combine the two results to calculate cost per death averted as a measure of cost effectiveness. Just to give you a preview, we will look at two strategies for vaccination. One would be a quote unquote uniform strategy, which means that I will equitably distribute vaccine across the entire population. And that's sort of the straw man model or the incumbent solution. And the other approach that we've thought about is what we will call as a seroprevalence based strategy. And the idea here is if a certain area has a very high seroprevalence, what that means is, fortunately or unfortunately, a lot of people in that population have already been exposed to the virus and may have developed natural immunity. And so the marginal value of the vaccine in that population may be lower than another population that has a very low seroprevalence. While not directly mapped or easily mapped, but you can imagine urban areas and rural areas just as a mental model. It's not a perfect mapping. Because within rural areas in the country, some areas may have a high seroprevalence and other may have low seroprevalence. Now, one point I want to make is that these seroprevalence-based strategies have been discussed quite widely, but have not yet been implemented at scale. So this is just us trying to predict what their effectiveness will be. And while we may argue that they are not easily implementable, they're at least more implementable than, say, checking the sero status of every individual before you vaccinate them. So recently there has been some discussion that we are overestimating the number of doses required in the country because so many people are already infected, and those who are infected may only need one dose of the vaccine. But imagine implementing this at scale, and then you'll have to check whether each person had been infected in the past. So run an antibody test or something. So at least our approach is not that cumbersome. It only asks for classifying regions or areas of high and low seroprevalence. I'll describe these and quantify these in detail as I go along. Let me see if there are any questions at the moment. I'm just laying out the premise of the study and the broad approach, and then I'll show some more details and numbers. Yes, Raja.
Now, if there are any questions, the audience can ask even now. Sarang has been kind enough. The point is that this webinar is more of a conversation, and it would be, I mean, while we can take questions later on also, but if anyone else has any questions right now, you can unmute yourselves and ask right now.
Yeah, and they may not be questions, they may be comments or arguments, and happy to have that interactive discussion as well.
Yeah, so Sarang, while we have not listened to your presentation in toto, but just curious, when you have mentioned about the total cost that you have calculated, now that we have different vaccines, and the state governments and the Indian government are being quoted different prices actually just for the uh, from the company's side, but as you mentioned that there are other costs involved ultimately. So would you be sharing any of that kind of data in your
Yeah.
presentation in the future?
Yeah. I'll show you the way we calculated the additional cost. So not the per dose cost of procuring the vaccine, just the material cost, but also other costs that are involved in getting the vaccine to the patient eventually. So we'll talk about that. I mean, we haven't done a lot of work on how to reduce the procurement cost of vaccine itself, because presumably we are in a supplier's market. It's hard to bring down the cost of vaccine in that sense. But we'll talk about the supply chain costs.
Because I believe that we may get some other vaccines, but there are significant differences in the direct cost of the vaccine themselves. So
That's right. So let me just say at this stage that we are going to not consider vaccines like Pfizer and Moderna, which require extreme cold chain capabilities of -70°C or -80°C. I'll describe the supply chain to you, and it will be clear that those supply chains cannot bear Pfizer or Moderna vaccines. Yeah. All right.
Sure, thanks.
Raja. Let's see. There may be a question. Yeah, will you consider lockdown, slowing of business also in the modeling? Not in this version, not in this particular paper. No, we are not looking at lockdowns along with vaccination. We had done a separate study that had analyzed when to lift lockdowns and how to use testing to inform lifting of lockdowns. This was during the first wave. It's an important question. If we are able to rapidly vaccinate people, then we may be able to do with fewer restrictions. We haven't done that analysis yet. Yeah, that's a short answer. Yes, there's a question from Anu Meha. Go ahead.
Yeah, hi, Professor. Wanted to understand a little more about seroprevalence. Don't know about it personally, and is it feasible anywhere? As in, what you explained seemed very complicated to implement at a large scale.
Yeah. So seroprevalence is essentially trying to measure what percentage of the population has been exposed to the virus, right? Have antibodies against the virus. ICMR has been conducting seroprevalence surveys in the country for the past year and a half, and they have estimates of seroprevalence in different districts in India. So that's already happening. That information is already available. What I was describing as being unrealistic was measuring the serostatus of individual patients. And that is not what we are modeling. Right? So just want to make clear.
Yeah,
right?
yeah. So my question was,
data is available, and it is somewhat feasible to use that data to prioritize vaccine distribution. Serostatus data is very difficult.
Got it. Understood the difference. I also wanted to know if any other country is using either prevalence or status data to inform their vaccination.
Yeah, so prevalence has been discussed. I think the issue is that the countries which are ahead on the vaccination curve are those which have adequate number of vaccines allocated for their entire population, right? So it's only a matter of timing. Whereas countries that are not yet there, and we are there, and there are countries in Africa, it's unclear whether they will have aggregate total vaccines enough to cover the entire adult population. We are claiming we'll have, but over what time frame? So those are the countries that may benefit more from these sorts of prioritization strategies, which is one reason why they have been discussed but not yet implemented, in my understanding. And it also needs evidence. So hopefully our analysis will be one piece of evidence to say when they are beneficial, when they are not, compared to uniform strategies. Sujata is also asking similar questions. Seroprevalence being used for, currently not being used for the vaccination plan in India, Sujata. There are reasons for it, and I'll leave that for the discussion part towards the end of the presentation. There are more nuances. We'll come to those. Deepak is asking, will the cost of hospitalization and treatment be included? Yes, so that's the plan. In the current presentation that I will show to you, we don't have that yet. We have separately done a study on estimating the cost of hospitalizations. We haven't yet integrated that with the analysis that I will show, but that's the aspiration, sort of put everything together. Yeah, thank you for that question. Okay, that's great. I really like this interactive nature. So I'll continue. Like I said, the effectiveness will be calculated using a mathematical model of transmission dynamics. These are usually deterministic models, compartmental models. You can imagine the population being divided into buckets or boxes, and people are uniformly mixing within their categories, and then they may interact with each other to transmit infection. So a susceptible box and infected box, when they come together, then there is an infection that passes on to the susceptible people. These models are governed by certain mathematical equations, which I'm not getting into, but these are some sort of differential equations which are solved easily, relatively easily on computers. What are the key components of such models? The blocks themselves, how finely am I dividing the population on various dimensions? So one key dimension here is the age groups, because people from different age groups are in contact with people from different age groups differentially, and that will determine how the infection spreads within each age group and then across age groups. And then similarly, the mixing patterns may be different in urban areas and may be different in rural areas. So one of the arguments usually put forth is, rural areas are far less densely populated as compared to urban areas. Possible, but at least some of the villages that I have seen, once you get inside the village, then they're fairly densely packed. Of course, one village is very far away from another village. And so it's not immediately clear. And so keeping urban and rural separate is sort of important. They may have different characteristics. And then we have made certain basic assumptions about what the vaccine actually does. So there'll be, again, two classes of all these compartments, right? So susceptibles, then exposed, infectious, and recovered. And then there'll be people who are vaccinated in these boxes and people who are not vaccinated. And the vaccine has a certain efficacy of reducing infection. So if I'm vaccinated, we assume that my chance of getting an infection is reduced by 70%. Again, data is emerging. This is a moving space. New evidence is coming all the time. But based on whatever we've seen so far, it seems like a reasonable assumption. And then, of course, there is infection fatality rate, case fatality rate. So all of those are factored in. Unfortunately, those data from India are hard to come by. We haven't done a good job of collecting very granular epidemiological data that can go into calibrating these models. Wherever possible, we've tried to use data from India. Wherever not possible, we have used whatever is best data globally available. And modelers from elsewhere have used that data, right? So that's sort of upfront limitations based on the data that we have. Of course, a lot of sensitivity analysis can be done on if the effectiveness of the vaccine is low, high, if the main effect of the vaccine is to prevent severe infections, or is the main effect to reduce transmission and infection. What I'm presenting, think of that as a nominal case. And once I show you the results, we can come back to some of these assumptions and discuss what the impact of relaxing them would be. Okay, so again, here is an illustrative example. I'm not going to name the state for which we have calibrated this model in this exercise, but we are doing this exercise now for more states. This is one large, highly populous state, let me just say that. And we've made assumption that seroprevalence in urban areas is 40%, and in rural areas is 10%. This is, again, as I told you, we started this analysis a few months ago. These numbers are likely to be different now, but we'll do some sensitivity analysis around these seroprevalence numbers. And we are doing two strategies, as I said, uniform and low seroprevalence strategy. If I do uniform strategy, I'm assuming for the moment that we have enough vaccines to vaccinate half of the greater than 50 population. Again, think about all of these numbers as placeholders. We have the engine to recalculate outcomes by changing these parameters, right? So I'm going to just demonstrate the idea to you here. And that's what we've been doing with other stakeholders. And then as interest increases, data comes by, the model can be rerun for more appropriate and updated data. Now, the low seroprevalence strategy is, again, as a mental model, imagine only targeting rural areas that have low seroprevalence, and then taking the entire vaccine supply, which would have been enough to cover 50% of the state's population, now vaccinating only rural areas. So then, depending on what is the total population in rural areas in that state, we can calculate what kind of a coverage can be achieved if that vaccine was used only in rural areas. Again, this is just an extreme. We know the way vaccination is rolling out is a mix of urban and rural, and that can be accommodated in the model. But for the numbers that I will show to you, either it is, so simply put, either it is vaccinating 50% of both urban and rural areas in that state, or vaccinating 80% of only rural population in that state, right? So those are the extremes. And again, we had started this analysis a few months ago. And so we have sort of a relic of the past that we assume that the vaccination is finished. This vaccination that I described is finished 100 days before the onset of the wave. Second wave, third wave, we can discuss. Currently, we have now, I can't show that result today, but we have now expanded the model where vaccination is progressing concurrent with the progression of the wave. So we just need to change a few terms in the mathematical equations to accommodate for this concurrency. But again, this is sort of clean setup where we first vaccinate a certain set of population and then the wave hits. Imagine that this is in some sense the best case that we could have gotten, but we didn't. Okay, and so under these assumptions, the curves that are being shown here are sort of daily deaths. Again, don't pay too much attention to the y-axis for the moment. Focus on these percentages. So the blue curve is for no vaccination, meaning if there were 0 vaccines, nobody was vaccinated and the wave hit, how many deaths would happen? And relative to that base case, what fraction of the deaths would be averted by a uniform strategy and by then a low seroprevalence strategy, the ones that I've described to you. And based on this picture, for this scenario, it shows that the uniform strategy would avert more deaths compared to the low seroprevalence strategy. So this delta is of interest to us, 27%, 32%, right? Not those absolute numbers, but the difference between the two, because that will help us choose one strategy over the other. Okay, there's a question, I think. All right, so Siddesh is asking, intervention in low seroprevalence would likely be more cost effective. May or may not be, Siddesh. You will see it depends on what do we mean by low seroprevalence, right? 40 and 10% are just some numbers, but we'll have to play this out for different seroprevalence numbers in urban and rural areas. Also, the cost of delivering the vaccine to a rural area may be higher than urban areas. And so the cost effectiveness may not be immediately clear. So that's what I'll show you in a few slides down. And there may be a mix possible also. We have not yet analyzed that in great detail. Okay, so here are first set of results, so to speak, on the transmission model. Again, these are just percentage of deaths averted, not absolute numbers. And then we are only looking at the difference between the two curves. So the blue is uniform strategy, the red is low seroprevalence strategy. X-axis is urban seroprevalence, right? So in the previous slide, I had taken urban seroprevalence to be 40, but it can go anywhere from 10 to 90%. And then rural seroprevalence is held constant at 10%. What that shows is there is a crossover point before which uniform strategy is more effective in averting deaths because that's lying above the red curve. But as the urban seroprevalence becomes much higher, so this is answering your question. As urban seroprevalence becomes much higher, then the low seroprevalence strategy becomes more effective, averts more deaths, because the differential between the urban and rural areas now is much higher. And so it makes more sense to protect the uninfected and susceptible people in rural areas than to try and catch up behind the curve in the urban areas, right? So there's a crossover point. And then we sort of repeated this exercise if the rural seroprevalence was already high at 40%. And just to illustrate that, these performance of these strategies are dependent quite crucially on these numbers. And so in this scenario that you see on the right-hand side, the uniform strategy is always more effective, right? Because rural seroprevalence is already 40%. And so we are never able to get that differential between the urban and rural seroprevalence. And so it makes sense to go for a uniform strategy where we are vaccinating both urban and rural. Okay, so this is just showing an illustration. We have been discussing this also with some people in ICMR, how to calibrate these models with the actual seroprevalence numbers that are emerging from more recent surveys. Those data are available for some districts, for some states, how to use those for multiple districts in multiple states. So that's an ongoing conversation. But this is demonstrating that under certain conditions, focusing on low seroprevalence areas as a strategy would be more effective in averting deaths. Okay, so that's just sort of pause here. That's the one part of our modeling framework, that if you have a constrained vaccine stockpile, you can't vaccinate everyone in a short period of time. You may consider prioritizing low seroprevalence areas under some conditions. Now, I haven't said this explicitly, but it was mentioned in one of the slides. We are still vaccinating the high priority segments in the population in all these calculations. So we are only looking still at the elderly and the 45 plus with comorbidities. Expansion to younger population has its own problems. We're now conducting analysis to quantify what would happen if the younger population starts getting vaccinated before all the elderly and high risk populations are vaccinated. It's likely to be less effective, but we are computing numbers to demonstrate that. But in this analysis, it's only the elderly and high priority that are vaccinated. Okay. Then let me now start talking about the other side of our framework, which is the supply chain modeling, which will yield us the cost of delivering the vaccine. So the assumptions that we've made here is we will be using the cold chain infrastructure of routine immunization program to deliver the vaccine until almost the last point of vaccine delivery. And then the session sites themselves, we have not made any explicit assumption. You will see later that we can accommodate private sector delivering vaccines and we can adjust the costs of that. But so far, we haven't seen any instance where private sector says, I will own the entire supply chain, entire cold chain, and move my own vaccines. That has not yet happened. So we will go by what you see in the picture here, the cold chain for routine immunization. Our approach is going to be to first calculate what would be the utilization of different assets, different resources in this supply chain for only routine immunization program. That will give us how much is the spare capacity at different legs of this supply chain to accommodate COVID vaccines. And then based on that certain strategy of vaccine rollout that I described to you, if these assets are in shortage, meaning we are capacity constrained, then we will calculate only incremental cost of adding resources to accommodate COVID vaccines. So just to make this more concrete, if in a certain district, in a district vaccine store, there is a large ice-lined refrigerator and routine vaccines use that refrigerator up to 70% of its capacity, then we can use the remaining 30% of its capacity at almost zero incremental cost. And if the requirement is beyond the existing ice-lined refrigerator, which we will compute, only then an incremental cost will be calculated, right? So we are doing some sort of a marginal cost calculation. We're not doing an average cost calculation. And that we've discussed this with several people. That seems to be the most appropriate approach in the current setup. Okay. Because that's why we want to utilize the existing supply chain rather than install a whole new supply chain. Okay, and just to again clarify and emphasize, we began this exercise several months ago where very little data on cold chains was available and we couldn't go to the states and ask them for this data. So we initially relied on publicly available estimates. Now, since then, we have been able to work with a couple of states to check whether using those publicly available data was appropriate and whether our estimates change if we take the data from states directly. And I'm glad to report that there hasn't been much of a change. So you know, the cost estimates based on publicly available data were fairly accurate. As I've said, although it feels like we're using the government supply chain or the public sector supply chain, the model will allow for private sector participation at the last mile of vaccine administration, but of course at an additional cost. Who incurs that cost? Well, someone incurs it. Either the private hospital incurs it and then recovers it from some other players, either the employers or the individuals themselves or the government, but someone has to incur that additional cost. So that's what the model will calculate. And I don't want to bore you with details, but there are many cost components. We spent a lot of weeks and months. Initially, Abhishek did a lot of hard work. He's a research associate here to capture each component of the cost, discuss this with several stakeholders, discuss this with experts like Sushmita who have done costing for vaccine supply chains and vaccination programs. Read through the Government of India operational guidelines of how they were envisioning the rollout of vaccination, how much supervision, how much training would be required, which personnel. So it's a fairly detailed calculation that we've done. But let me just show you what kind of results we are able to get. So for this particular state, the large populous state that I did not name, we are able to show what would be the utilization of different assets. So these are shown on the x-axis. WIC is a walk-in cooler, large ice-lined refrigerators, small ice-lined refrigerators in rural and urban areas separately, and then ANMs or vaccinators. So it's not just physical infrastructure, but also human resources, and then transportation vans, refrigerated vans. For each of these, we are able to calculate the utilization of those resources with and without COVID vaccines. So what I'm showing you here is with COVID vaccines, but we had first calculated it without COVID vaccines only for routine vaccines, childhood vaccines, and then overlaid on top of that the volume of COVID vaccines that will flow through. And then these box plots are showing you the variation across districts in that state. So not all districts have the same infrastructure. You will see that in some districts, the utilization goes above the red line of 100%. So those are the districts that will require infusion of capacity, augmentation of capacity, and that will be expensive and will be costed out. In case where the box plot lies entirely within the 100% line, which means that the existing infrastructure in those districts is adequate and no additional cost will be incurred for COVID vaccine rollout for those assets, right? So broadly speaking, for this state, for these sets of calculations, ice-lined refrigerators, small ones are not a constraint. Large ones are constrained in 80% of the districts. So that's what this 81% is. Vaccinator or A&M capacity is a major problem in urban areas in this state. In 98% of the districts, additional vaccinators will be needed in urban areas. So now you can see the role of private sector because typically public health systems are weaker in urban areas. Some of you would know this compared to rural areas. And so you may have to then augment capacity using private sector, but that will come at a cost. And then transportation capacity is a constraint and will need infusion in 39 or 40% of the districts. Now, all of these calculations are for a uniform strategy, and then we can do a recalculation of these numbers. They are slightly different for seroprevalence-based strategy, because remember, in seroprevalence-based strategy, all the vaccine is being pushed to rural areas, and so the numbers are going to be slightly different. Okay. So let me, if this is okay, and again, feel free to ask questions. And we've done similar calculations for multiple states. Maybe I'll have a chance to show what that shows for multiple states. But then once I know which assets are going to require augmentation of capacity, I can cost out that augmentation. And based on that, we calculated that the cost of additional cost per dose of delivering and distributing the vaccine is of the order of 40 rupees per dose, 35 rupees per dose. And then if you add on top of that cost of the vaccine itself, which then we had assumed to be 200 rupees per dose, but this is a placeholder, right? You can change it to 150 rupees if you want to take the manufacturing cost. I'm not a big fan of taking 400 rupees or 800 rupees because that's the price in the private sector. We are interested here in the cost, not in the price, because what matters to the society is the sort of the cost that is incurred to undertake an economic activity. Rest of it is transfer payment between different players. And then we can also calculate the total cost under each of the strategies. So under uniform strategy, under seroprevalence-based strategy, and you're seeing that there is some amount of differential between these two strategies. And I'll then sort of combine these cost estimates with the effectiveness estimates that I showed you earlier. But this is the aside. For a moment, I wanted to say that a side product of this analysis or this project was that now with the tool that we have for supply chain costing, we can help any state government to calculate what the unit cost of delivering vaccines in their state is going to be, and what is the total budget that they need to be prepared for. And I must say this, that when we did this analysis, the rules had not come out. And so the states were not sure whether they will be incurring this cost or not. Now, though, the ball is in their court. And so this estimation of the budget is becoming increasingly important. In fact, tomorrow we have a discussion with one of the states of how this model could be helpful for them to do their budgeting. So just this is an aside, a sort of a byproduct of our analysis that state can use for the planning of their vaccination rollout. Okay. So again, this is just sort of summary of what I've said so far on the supply chain side. In the interest of time, I will now move on and combine the results from both the analysis to now calculate what you see on the y-axis is cost per death averted. Again, we can focus on absolute numbers, but most of us don't have a good benchmark of is 30,000 per death averted okay, or 40,000 per death averted okay. We can compare the two strategies, right? And so what we are again seeing is that there is a crossover point. So this is graph again for rural seroprevalence being very low. And we are seeing that unless the urban seroprevalence is up to 60%, uniform strategy is cost effective compared to a low seroprevalence strategy. But once you are beyond that threshold of 60%, then it is more cost effective to adopt a low seroprevalence based strategy, meaning prioritizing rural areas to vaccinate, right? So the differential again matters, and then we can recalculate these numbers for other combinations of seroprevalence. But the sort of larger point here is whatever you saw in the effectiveness curves, the threshold or the crossover point, that kinds of holds even for the cost effectiveness metric, because the unit costs themselves are only slightly different across the two strategies, right? So that sort of brings me to the end of the presentation, and I'm sort of happy to take more questions after this. I think the main contribution or attempt here is to create a framework, a flexible modeling framework that can calculate and predict outcomes and costs under different vaccination strategies. Two strategies that we have considered so far are the uniform strategy and then a prioritized strategy that targets low seroprevalence areas in a certain state. As I've said, the model is flexible. We are now utilizing the same modeling framework to look at what happens if you open up younger population for vaccination much faster than what you ideally may have wanted to do. And so in that sense, the model can be used for many other outcomes as well. And then the supply chain model itself can be used separately for planning purposes. Okay. Okay, so that brings me to the end of this presentation. Happy to take questions or criticism or comments at this point. Raja, please feel free to moderate.
Yeah, so thank you so much, Sarang, for the excellent presentation. We are now open for questions. We can unmute and ask questions directly. That would be better. We also are fortunate to have Dr. Evita Fernandez, also Dr. GC with us. I'm sure they will have a few questions too. Anybody has any questions?
I'll address Suman's question. This is already in the chat window. Gives opportunity to other people to sort of think about their questions. So yes, the deaths that I showed are, maybe I went too fast on that slide. Let me show that again. Here. These are percent deaths averted, not percent absolute deaths, percent deaths averted compared to a baseline of no vaccination. So vaccination is going to save deaths compared to no vaccination, but then which strategy prevents more deaths, averts more deaths? So that's the y-axis, Suman. I hope it answers your question.
So Sarang, if I can ask one question, you see, you had made this model based on the previous wave. And currently we saw some mutation. There are some scientific variations which would have happened, like mutation. And the previous wave we saw, at least initially, it was more of urban, and then we saw mutation, and then we saw again the urban population getting affected initially in this wave, and now the rural population also getting affected. So how would that affect your model, in the sense that in the future, if we again look at the zero prevalence strategy, but with mutation, would it completely become topsy-turvy, or we can still work along with this?
Yeah, so that's a good question. See, one point to make here is the transmissibility of the variant is higher compared to first wave, but that transmissibility is higher for both urban and rural areas. So urban second wave compared to urban first wave, rural second wave compared to rural first wave is probably similar differential. And our goal here is to look at urban versus rural allocation. So that's one point. But you are correct in that if the decision maker, policy maker was serious about seroprevalence based strategies, then they would have to constantly adapt, right? Because the seroprevalence is changing as you're rolling out the vaccine and the epidemic is also running through your population, right? So we are not, unfortunately, there yet, where we are sitting down with policymakers, principal secretaries of health and saying, hey, how do we use this now? But if it came to that, it would require updating of the model inputs periodically, which is what happens even for those Sutra models where you are estimating cases for the next 10 days, but you have recalibrated the model based on the evidence until now. You don't continue to use the parameters that you were using 3 months ago. You're constantly updating them and then running in the future. So a similar thing would have to be done even in this case. Yeah.
Thanks, Sarang. Are there any other questions?
Srinivas has put something in chat window saying, did you not consider data from Telangana and Andhra for any reason? Yeah, just paucity of data. I mean, so these states didn't even have their data up on any public domain that we could download. Simple things like overall in the state, how many ice lined refrigerators there are, simple data of that kind were not available. We did approach different state governments and we've got differential response. Off the record, I can tell you who have been talking and who have not been talking, but let me stop there.
Yeah. So I think, Sarang, in terms of supply chain, are there any thoughts on, at least from the bed side, ICU side? Last year we had discussed about railways converting the train coaches into something which could be used. Are there any strategies to enhance the supply if and when we achieve the capacity? Supply side may also be a constraint. So do you have any thoughts on that?
Yeah, so no, that's a sort of valid set of concerns. The way I'll respond to that, Raja, is saying that today we just don't have enough doses. As we ramp up manufacturing capacity, it may so happen that we have enough vaccines, but either we don't have enough demand due to hesitancy, or that we do not have enough cold chain resources or transportation resources or people to put jabs in patients' arms. We have a way to calculate that and foresee that, right? So that is the good part about this model. One small state in North India has already told us that they don't have enough transportation assets. And so we are trying to work with a consortium called ACT Grants, who are trying to help state governments to buy assets. And so a model like this can also be used to say, which asset should you buy? And so it'll help donors to put the money in the right place. You don't want to just take the state's word for it and say we need more vans, when actually they may need more ice-lined refrigerators in some districts. Or you can reallocate and redistribute existing assets to economize. So our model can help plan those activities as well. Again, discussions are ongoing with these different stakeholders. This is a complex space.
Yeah, thanks, Sarang. Thanks once again for the excellent presentation. I think we have run out of time. Sincere apologies for the initial delay. Yeah, this great work that we have done, while we wish that COVID goes away, but there is a realistic chance or risk that COVID will not go away completely soon, and the immunity probably is not lifelong. And whatever work you are doing currently, I think would be pretty much useful in the long run too, beyond this wave. That once we look at different strategies, I think future governments would also find it very helpful. We wish that COVID goes away. If not for COVID, some other health problems can be solved by your work. But thanks so much for what you have done and for sharing with us today. Thank you so much, everyone, and all of you have a good evening. Thank you.
And I would say if people are interested and they had questions or ideas, they can reach out to me. I think the email address is available. Otherwise, we can facilitate that. Thank you.
Thank you all. Thank you. Bye. Good evening.